So hi everyone, my name is Michael Meng, CEO of Stellar Health. Thank you for joining us today and over Zoom. We're excited to be hosting our annual Board of Advisors Summit in person this year with a panel discussion on the future of delivering value-based care. We have with us today a panel of successful leaders in healthcare that will be discussing two topics: bricks versus clicks in primary care VBC models, and VBC success through employed versus non-employed providers. With that, I will introduce our panelists. We have Dr. Robert Fields, who's the EVP of Chief Population Health at Mount Sinai Health System. We have Dr. Catherine Gaffigan, President of Arizona and Northwest Mountain Markets at Aetna, a CVS health company. Dr. Shirin Peters, the founder and CEO at Bethany Medical Clinic here in New York. And Robb Vorhoff, Managing Director, Global Head of Healthcare Group at General Atlantic. We'll also differentiate, and Dr. Robert Fields, I'll kind of call on you to start introducing yourself a little bit and maybe why you were interested in this panel today in value-based care and what we're doing perhaps at Stellar Health.
In 30 seconds or less.
30 seconds or less.
So I'm interested in all those topics. I primarily as a driver I was an independent family doc now over 18 years ago. Started my own practice, took a mortgage on my house, did the old-fashioned way, took a loan, the whole thing, to start a practice with a friend of mine, and took care of patient populations, primarily underserved Latino patients in Western North Carolina. My partner was heavy into geriatrics and was not a recipe for payer mix success in primary care and fee-for-service, and became aware of how broken the system was. It's not sustainable to provide high-quality primary care in the way it was modeled, and sort of was lucky enough, actually, didn't know what it was called, but lucky enough to find my way to try to figure out how to solve it. So that's what drives me. I'm interested in the seller piece, and I'm particularly behavior. I spent most of my career trying to affect behavior change among physicians and other administrators, and very interested in the model that you guys have created here to do just that. So I appreciate the time.
Thank you, Rob. And Dr. Catherine Gaffigan?
I am interested in value-based care because from the payer perspective, I believe we have to start figuring out, we have started, but we haven't figured out how to pay doctors and hospitals to keep people well instead of only paying them when they're sick. And so that is my driving passion and has been basically since I really got into healthcare, 10 plus years ago. So thrilled to be here today.
Dr. Shirin Peters.
Hi, so I am a primary care provider myself, and really grateful to be here. It's such a nice break to be at a clinic and doing something completely different. And I'm definitely interested in value-based care for selfish reasons because I practice, and just a lot of the efforts that we make as physicians and medical providers are not incentivized in any way in our current care model, and I think companies like Stellar are offering a way for us to get paid for the work that we spend all our time on. So, very excited to be part of the panel and to be a new user of Stellar as well.
Thank you. And Robert Vorhoff.
First, I think I'm on the wrong panel because I'm short a few degrees in academic achievements, but it's nice to be up here with this elite crew. So I lead healthcare investing at a growth equity firm called General Atlantic. It's all thematic growth investing. The way we try to do that is have our teams dedicated to sectors. Myself and my colleague Armand in the crowd spend all of our time focused on the healthcare space. The idea is to be closer to and understand the trends that are defining that space and to find fertile areas within healthcare to invest that will create long-term growth, ideally to build companies and create equity value on behalf of our investors. Part of our interest here, and for a bit of context, so General Atlantic led the Series B investment round in Stellar Health earlier this year, but the shift from fee-for-service to value-based care in the US has been our top investment theme for the last 7 years. And I think we've invested as much as anyone else in the investment environment against that theme in all parts of the value chain, from vertically integrated Medicare Advantage plans to risk-bearing primary care to value-based enablement platforms. And that theme has extended more recently into other populations outside of Medicare Advantage, as well as into other specialties and business models. It's a pleasure to be here.
Thank you, Robert. So we'll jump right in. It is now 2021, and digital and tech is everywhere. And so, curious, do any of you think that a web-based approach really has a place in the delivery of healthcare? How much and why? If anyone would like to chime in.
Fine to start, I guess. Sure, I mean, of course it has a place. I think what is a little tricky, I think, for me, seeing what's emerging in the market is the thought that it could be all-encompassing. I mean, I think we're learning that that's probably not the case. People are complicated. People need different things in different parts of their life. I think absolutely there are a significant fraction of the services we provide in healthcare that can be provided in a digital format equally with equal efficacy and actually probably better customer satisfaction than the standard model. Absolutely true. But there are times where that is insufficient. So I think one of the things we recognize as a system is that it's a both and. You can't be recalcitrant and sort of hold on to the bygone days of in-person visits for everything. At the same time, we see gaps, and we see it because the all digital companies often come to us, for the bricks and mortar piece. So I think it's obviously a balance.
And Catherine, from maybe a more payer perspective, seeing some of these models come out, what do you think is kind of the future there?
Yeah, and I should just say that this is, kind of my own personal perspective. This isn't, CVS's perspective. This perspective. I have the same concerns that Rob does, right? Like, I think we strongly believe that there is a place for telehealth. When I say that, I'm talking about like patient to doctor, through a screen, right? Not telemedicine, which is more of a specialist to physician type of arrangement. But as a payer, I want to know that my member is going to get good care that way, right? And we were talking about this in our one of the meet and greets. Like, there is a need for laying on of hands at some point. And so how you enable that when maybe you started a relationship virtually is going to be extremely important, right? And so I think that my concern just personally is how do we close that new gap, right? Between, now I've had a virtual visit, but I need somebody to lay hands, right? How do I get them there? Who do they go to? How quickly can they get there, right? Are they gonna still feel that that's convenient enough that they will go there, right? So I guess, maybe as a physician, but certainly as a payer who's interested in making sure that the care we provide for is great care and high quality care, that just kind of, adds a new dimension, just with respect to another, potential fragmentation in the system if we're not careful.
Yeah, thank you. And Shirin, I suppose having run a clinic that actually is pretty forward from what I know, what are some of the areas where you do use, web or digital to really interact with patients?
So there are definitely specific situations that it's extremely useful to be able to reach my patients via telemedicine. Anything that doesn't involve or doesn't require a physical examination. So in my experience, like follow-ups, so a call to discuss, a telehealth visit to discuss lab results is on a different level, much better than an in-person visit. A mental health counseling visit, nutrition assessment visit. There are a lot of things that we can do using telemedicine that we were not able to do with only in-person visits. And patients really I think the big pro to web-based care is that patients really love it and they use it. People have been so excited to have that opportunity to log on, not have any barrier to make an appointment, transporting yourself there, putting yourself at risk for COVID or other things. So people ask more, and I think that's a big pro. We're getting a lot of overall virtual care allows for more medical attention. So my patient may call me when they're homesick and ask me what supplements they should take, what is their data to support. And I would not have had that interaction before telemedicine. So there's definitely a lot of pros, and it's very useful in very specific situations. And the cons, I think, are that the patient-provider relationship is really eroded when it's in a virtual visit. I mean, there's boundaries, restrictions, limitations to what you can do, and a lot of that is what we lose when we aren't face-to-face in a private room, just provider and patient. So that's my take on it, which is very much in line with what you both said.
I totally agree. If I can say, I mean, I think at this point we all know it because we've had enough experience during the pandemic with this manifestation, but I think we'd be remiss to not explicitly say out loud is that there's massive potential in the digital infrastructure we've created and the behavior change we've created as a result of the pandemic, honestly, to fuel telemedicine and that engagement not only on the physician side, but on the consumer side, right? They're more willing to engage in digital care than ever before. Great. But there's also massive risk on the equity side, and again, that's the part that I think we should be really explicit about, even though I think at this point everyone's very aware of it. We lack infrastructure to have it be equally accessible. So while there is massive potential to change the economics of, for example, like Medicaid, you can deliver care at a much lower cost, per delivery, per episode, via a digital environment than the bricks and mortar environment, which is great. It actually very much can change the economics of caring for Medicaid patients, which is, again, have lots of potential. But without the infrastructure there on the consumer side, the more likely scenario if things progress unchanged is that you make disparities worse, which is exactly the opposite of what you're trying to do. And so I don't know if it's necessarily cart before the horse, but both things have to happen simultaneously to not amplify the effects of it.
And perhaps, Robert, on that note, what have you seen in the investment landscape in terms of where the innovation has been?
Yeah, huge topic. So virtual care has exploded over the last year and a half, frankly, because it had to. So every company out there has grown at historic rates. Every company has raised capital. It's probably been within that space specifically, up 5x the amount of deal and capital raising activity. I think it was a showcase moment to illustrate and highlight the access that the virtual care modality affords, and they do that, frankly, for populations that have not had equal access and at a lower cost, to Dr. Field's point, which is fabulous. I prior to that, was a pretty big skeptic of telemedicine, at least as it was historically defined, which was for most interactions a phone call with a physician, any physician. That physician didn't necessarily know anything about your clinical history or even your benefit coverage, and we as the patient would have to think of what was the relevant information to tell them over a phone call. And I think what it's showcased is how it can be a very effective modality of care as part of a broader care model. And where you've seen really exciting innovation, Mike, to your question, has been now that we've exposed, frankly, because we had to, so much more of the population to the benefits, the convenience, the speed, the ability to affect a lot of conditions or have a lot of effective interventions across a broader range of conditions with virtual care. Now I think people are trying to think about how can that modality be incorporated into broader models. And I was interested, we were looking at some data earlier this week where historically everybody that had a telemedicine visit still liked it, even though it was a pretty low utility intervention. And as people have gotten more exposed to it, you've had more of the population, I think, get comfortable with that convenience, and in fact, going forward, will demand that as a modality of convenience as part of what they should expect as a patient or consumer. What's interesting now is We had so many companies in our portfolio that were traditional bricks and mortar providers in primary care, providing care into the home. All of those companies went from 90+% in-person care delivery into 90+% virtual care delivery during the pandemic. And then the big debate was, all right, once we got post-pandemic, I thought we were a little closer than maybe we are, where would that balance out? And it's going to end up at much lower percentage of virtual care delivery, but I think at different settling levels depending on the population that they're treating and the scope of care that they're trying to deliver. We looked at some data earlier this week, and where you see the most comfort with virtual care visits, yet they still prefer in-person visits, is with affluent women. And where you see the least comfort with it is where you see low-income populations or elderly populations that have the strongest preference for in-person care. So I think there's been a ton of learning. We've exposed the population to the good and the bad about that modality, and now there's a lot of innovation trying to figure out how to most productively incorporate it into broader models.
And maybe on that, what are some of the best ways you've seen it incorporated that maybe we don't hear about all the time, in terms of people attacking this idea, adding a service that is digital or virtual so that there are access points that solves adjunct to maybe what's already out there in delivery?
I don't mind starting again. One of the ways that we've thought about it, especially on the equity piece, is we have 125,000 full risk Medicaid lives, and worry a lot about the access issues there. So one of the ways we've thought about it is, can we, there are companies that have formed like these kiosks, you can go as sort of hubs for digital care. I'm not sure people want to get care in a kiosk, but taking that same element with the growth in telehealth and having community health workers at trusted sites in communities to be a digital hub so they can facilitate a telehealth visit with a physician. We started one actually with a public charter school in East Harlem, where we have a community health worker facilitating telehealth visits to avoid the access issues, right? And so then we have arrangements with behavioral health, physical health providers with FQHCs in the region that are geographically close, so that if a brick and mortar visit is necessary, then they can engage with those providers. And then of course the community health workers can handle those social care needs as well. So along those three domains, physical, behavioral, and social, we have an access point from a trusted partner, i.e. the school, that happens to serve 1,200 students and their families that are close. Turns out that about a third of those are in our risk pool. So by serving the school, with sort of the value there is that, hey, we're creating a healthier environment and have a halo effect, right, on our members. That's one idea we had to try to figure out, all right, how do we take telehealth and have it be a facilitated model to try to deal with some of those equity issues. That's one example, but there are many others.
Yeah, I'm hearing a lot of access, right? Ability to meet people where they are. And also triage is actually what I heard in there, right? The ability to figure out the front door might be this, but then how do I get them to the right place? Any other kind of innovative things that you all have seen?
I think just to pick up on the, triage at the front end, certainly. Care navigation, so helping to find the right specialist, the right site of care, which is a big component of driving higher value into care. Follow-up visits, like Dr. Peters mentioned earlier, all highly effective. And then you get into certain specialties. I think where you've seen the most innovation and exciting potential in the application of virtual care has been in behavioral health, and the ability to maintain a longitudinal relationship with the patient, where you can scale up or down the intervention based on the acuity need. And that's not, hey, you're feeling anxious or depressed, great, let's schedule an appointment a month from now. It's providing almost immediate real-time connectivity to a provider or care team, which is pretty exciting.
I might add to that, the remote monitoring also, has emerged at the same time, not pure telemedicine the way we've been describing in terms of a visit, but certainly the same idea of real-time impact on chronic conditions. There are many, many really bad examples of using remote monitoring that are really just a billing mechanism, but I think there are an equal number of really positive examples of active management, and that's not the sort of standard model, which is diagnosis, treatment, diagnostics, and then very intermittent follow-up. I'll see you back in a few months, so figure out where you're at then and titrate again. Changing that to a more real-time, more active management, similar to the behavioral health that Rob was mentioning. I think that's also emerged pretty dramatically in the course of August.
Dr. Fields, on that point specifically, do you think that remote patient monitoring or something along those lines will prove itself out over the long run, or is it still kind of in its infancy of figuring out whether it is or not? Do you think it's already proven, or still a little bit of ways to go?
Oh, very much in its infancy, for sure. I mean, I think the feds, I think, were appropriately concerned that it's ripe for fraud, and I think they're probably right. That it's not just about the technology, like it rarely is. It's about the care model on the other side of the technology that makes the difference. Having, I was gonna. It's not a place. There are companies out there that make a lot of money on, collecting data and regurgitating that data in some way that affects nothing on the other side. But it's a fancy tech. And if you're not actively managing the patient or engaging with the patient on the other side, it does very little. But I think there's opportunity. I think we'll learn over time as it grows which models work, which don't. And my guess is that it's going to be a lot more based on the care model rather than the technology. But the technology is really commoditized at this point. There's nothing fancy about collecting blood pressure data and weights. That's easy. It's all that other stuff. There is a lot of noise right now, so I think it's far from proven. Is my sense.
Just to add on the models that I think work well, or that I've seen work well, all private practice groups that I know incorporated telemedicine in some way into their practices, and a lot of telehealth groups kind of took off or exploded during the pandemic. And I think that the strongest models were brick and mortar practices or care groups that had clear clinical leadership on building out the telehealth protocols, because that's the important piece. I mean, triage or any of the ways that we were describing it, the important piece is getting the right patients seen by telemedicine. So I think that decision making should be from a team that is seeing patients in person and making those decisions about who should be seen in what setting. So that's just my observation.
And relatedly, I would like you all to react to a statement I'm going to make. I met with a primary care doc recently who said, all this digital health, telehealth, it's actually all the things we were doing before anyways. We would take these late night phone calls, right? If I'm a primary care doc, we would take the phone call over dinner, and all it did was now we get paid for it. That's really all this shift has been. True or not true? Is there more to it, or is that really just what has happened?
I think there's more to it. I think there's more to it than that. If you're doing it right, I mean, that is true. That's a true statement. Definitely. I'm not sure. What I struggle with is that last bit about now we just get paid for it. I'm not sure that's the right end goal either, right? So it is convenient, but there are more tools that when we opened our practice, remember we used to have a cell phone, and I would trade cell phones, and the patients just have the cell phone number, and they were surprised they didn't get an answering service. They started telling me, I want to talk to the doctor. I'm like, this is Rob. I'm sorry. But that's great, but it's not the tools that we have now available to us in terms of having video and getting that experience. So now you've added to the interaction, seeing the context of the home, which has been helpful, adding remote monitoring to that. There are many more tools. It's way more powerful than just taking a phone call over dinner. And also the consumer behavior is really different, I think, in many examples. So I think I wouldn't underestimate that. That feels different somehow than taking those phone calls. So I say it's related, but not exactly the same, and way more powerful, with much more potential. That's sort of thing.
Just to build on one point Rob made, so part of that survey data I referenced earlier, the last categories were those that have been exposed to a video visit and those that haven't. Overwhelming increase in comfort level once they've had that video encounter with a physician relative to just the concept of, am I comfortable with virtual care delivery?
Yeah, that makes a lot of sense.
Interesting. Yeah, I think that that statement is true, but I also I completely agree with both the panelists so far about
Both Robs.
both Robs, exactly. that there's much more to it. So in a telemedicine visit, I can do a lot more. I can ask a lot more questions. I can see things, and that adds another element to what I'm able to do. Although it is very limited and restricted. It's different than a phone call, but not that much different.
Yeah, I think there's two big things. One, you've lowered the barrier to access care from a convenience standpoint, from a regulatory standpoint, from a cost standpoint. And there's good and bad to that. And the government's job, to the extent that it's now going to be reimbursed, is to try to assess, is that appropriate utilization, and then what's the right compensation for the provider for that unit of care that's being delivered. That's complicated and hard to police, and go back to the remote patient monitoring, things like that, room for fraudulent activity. Where I get really excited about it is, one, the exposure to that modality for a much larger percentage of the population will be a great, I think, silver lining coming out of COVID. But what's really exciting is how that modality now is going to be integrated into broader care models. And I suspect, Mike, it's somewhere where you want to go. If you think about it in a pure value-based model where you no longer need the policing or coming up with a fee-for-service rate, and instead it's just lowering the barriers to access to care, more effective triaging, more efficient and maybe effective follow-up. And then the provider organizations can incorporate that modality and calibrate the utilization of that modality based on what they think is most clinically appropriate based on the patient need and profile.
Yeah, and so from the payer perspective, what you just said, Robert, is really important because first and foremost, I want to pay providers for the care that they deliver. And I think we've had the issue for a long time that we don't pay for your dinner phone call, right? I also don't think that it's appropriate to maybe pay at the same level for that, right? And I think that is something that we're going to have to, figuring out what that looks like, and do we pay more for a video visit versus a phone call? State of Washington, as an example, from an equity perspective, said, audio-only visits are going to count just the same way that a video visit counts. Well, okay, but how are you going to bill that, right? And I don't want to, make this, too much about esoteric billing issues, but there are going to be challenges with this, and it'd be really fascinating, as you said, for all of us who have to figure out how to pay for that. And bill for it, what that's going to look like. Because again, I still believe strongly that in situations where there is a need to lay on hands, right, I don't really want to pay for the same visit twice either. And I'm not saying that just as a payer, I'm saying that as a person in this country who, if we're not careful, we could really, just kind of increase our costs in a way that doesn't actually drive, true value, right? And so I think it's going to be a really fascinating piece of this puzzle. I would be the first to say I'm thrilled to see that, the pandemic, forced us to get to this place, right? I mean, you said it. I mean, I talked to large physician practices, and my friends in St. Luke's could probably say the same thing. They said they literally went to, from, 2-5% telehealth to overnight 95% telehealth, right? Like over a weekend in March 2020. And, they were calling me saying, like, how are you going to pay me for this, right? Which is appropriate that they would ask me that question at that time. But, as things shift, right, we're going to have to figure out. I mean, we used to say it was okay to pay less for a telehealth visit because there was lower overhead, right? Pandemic hit, and we all said, nope, we're going to pay for it all the same. And maybe that's appropriate over time, but maybe it's not, right, from an overhead perspective. And again, I don't want to make this about, money, but I do think, our healthcare costs are going up, and we do have to think about, like, what's the right balance of all that. And it's a great problem to have because I do think that there's, an increase in access, hopefully, based on, some of these changes. But there'll be some stuff for us to work through in the next few years.
Well, I think, Catherine, what you and Robert both said, which is, for me at least personally, value-based care always underpins or overlays all of this, right? Because without that, you're trying to make all these micro decisions around what should that be paid for, was that visit the same as that visit, and if everyone is delivering on value-based care, maybe that is up to the individual provider group or clinical model.
Well, I agree with that. I guess I would just be really careful about how you define value-based care, right? Because, you know, if you're still fee-for-service and I'm setting like a shared savings target, then I'm setting it on your baseline, right? And again, not to get too esoteric in terms of how you do value-based care, but we're not really talking a lot about capitation here, frankly. And so if you're talking about it from a capitation perspective, it's actually a lot easier to have this conversation because, you know, Dr. Robb can do whatever he wants, basically, right? We're gonna, determine whatever, the appropriate payment is, et cetera. But I mean, 85% of my members are in self-insured plan sponsors, right? They're not, like, capitation is very hard in that situation, right? And so I think there's a lot of like other things that have to happen in this healthcare industry for us to get to a place where we've got enough value-based care, which is really capitation, like real value-based care, before, some of these issues aren't going to be issues.
I think that's right. I think it's a question of who holds the responsibility, and maybe for me at least, the North Star is hopefully all groups move to full, real capitated risk eventually, but it's a fairly long journey and we're pretty early on in it as well. I do want to go back to one more thing on clicks versus bricks, which is, do any of you believe that there is a possibility for a virtual first model? We've seen a ton of companies raise money and say, yeah, we're going to be that virtual first business, and then supplement with Sinai's bricks and mortar or Dr. Shirin Peters clinics right in person. Is that really possible? Why or why not?
Well, they're out there now, right? Kaiser came out with a virtual primary care model. Aetna is launching one. There's probably other payers that I'm just not aware of. And Amazon Care is out there. So virtual first exists today. I have the question that I kind of raised early in this panel about, how you ensure that you go from virtual to in person when necessary, right? And I don't, it'd be really fascinating to see how this model bears itself out, because, I don't know, as a physician, I'd be more inclined to think about the way that Shirin described it, right? Where you establish a relationship first in person, and then you can do virtual visits as appropriate, which is kind of also how Medicare, CMS had established the expectation around virtual visits, right, and paying for virtual visits. So if you don't have that connection into how do you get to relatively convenient follow-up care, you're going to struggle, is my hypothesis. I mean, I guess you could also argue that maybe folks initially get into a virtual type of primary care relationship. They're relatively young and healthy, they don't need a lot, and then, as they progress, they realize they want somebody that's in person. What I would say about like the Aetna model, which obviously I know the best, like what is exciting about it is, you're seeing the same doc all the time, right? It's unlike kind of traditional telehealth, which was, you see whoever shows up, whenever you want your appointment, and they have a care team, right? And frankly, like, that's not always the case in a primary care environment. And so, like, in some ways you could say, hey, there's actually some real, opportunity here, because again, you can be at scale a little bit, and you can offer, some kind of care team aspects that, aren't always available. Just, you've got, primary care doc in the community. So, I guess bottom line is, we are at the cusp of some really fascinating, kind of movements in the industry here. Sorry.
No, that's, and I would say that, as Catherine was saying, sure, it's possible because they exist today. Our experience in New York is we have a couple of folks in our network that are virtual only, virtual first and virtual only, and they frankly have struggled to get members. And inevitably, they all come back to, well, we're going to have to build at least 1 or 2 brick and mortar sites somewhere, right? Because they can't fulfill the needs all the way through. So, again, like we said in the beginning, I don't think it's for everyone. So I have 2 comments about it. One is, yes, it's possible, but for whom, and for what purpose? And I don't think it's not gonna solve healthcare. Like, you're not gonna solve the issue of complex Medicaid patients with behavioral and substance abuse issues on a digital-only strategy. You're not going to solve the issues of complex Medicare patients in a digital-only strategy. Does it help? Absolutely, and it can be a wonderful adjunct in all of those things, but I think inevitably people will want something more than a video or a text. And so what are those companies going to do? Either they partner with folks like us or some other system or another clinic or something, or build their own. Inevitably, that's been our experience, certainly in this market.
Right. I agree with that completely. And I mean, virtual only, I just think is deficient care, right? It doesn't, to me, make sense as a primary care model. But virtual first, I think, is inefficient. I mean, to be soft, but like wasteful, really. I think, in my experience in practice, offering telemedicine to any patient who wants it, who wants to become a new patient in the practice and see us via telemedicine, about 60% of the people who connect with us for the first time virtually don't get any care at that visit. There's nothing I can do for them, and I tell them to come in the next day. So that's, to me, extremely wasteful and not the right approach. So that model is leaving it to a patient to self-select whether they should be seen or want to be seen virtually or in person. And it's more complicated than that if you want to give good or excellent primary care. So I think virtual in certain situations is a better model.
Yeah, I don't think there's going to be virtual only solutions, because I agree with the clinical concerns that have been raised by more qualified perspectives. But I do think you're going to see a lot of virtual first, and primarily in the commercial population. And I think the thinking there is that a lot of the magic in having improved plan performance or risk-bearing primary care performance is around engagement and being able to build a trusted relationship to at least influence, if not control, care pathways when people start to utilize the healthcare system. And if it's virtual first, you are creating a connectivity point. And if that's a phone call with a random provider, far less trust is established and influence accrues afterwards. If that is a continuous relationship with the same care team with the benefit of clinical history and claims history and benefit knowledge and ease of access, and you need to touch that first, I think of that more as a gatekeeper model, which was very effective, just highly inconvenient and disruptive in its historical deployment. And a virtual modality that is super convenient, I think the potential there is that you can get the best of both. But I do think you're going to see it grow, particularly within commercial populations.
Thank you, Robert. And I do want to shift gears a little bit. You hit on one word that really means a lot to me, which is engagement, right? I feel that in order to deliver, whether it's digital health or value-based care, engagement is what is needed. And not just engagement from payers to their providers, whether it's a value-based care contract of real kind, perhaps, whether it is systems or clinically integrated networks to their providers and staff, or from those providers and staff down to their patients, right? So all along the way, a lot of engagement has to happen. And so for our second topic, curious, we've seen a lot of these full stack integrated, vertically integrated models come out for value-based care, Oak Street, ChenMed, Iora, et cetera. And I think the thing I want us to question today is how important is employing those docs versus not necessarily employing docs, and why in delivering value-based care. And so Dr. Fields, as an example, I think Sinai has both, right? So you balance both things at the same time. Catherine, you also have within your book of business both, and you get to see both. So I'm curious how you guys think about that question of how important is employment to the delivery of value-based care?
Well, my immediate response is probably less about employment and more about the degree to which the incentives are aligned. My ability to affect behavior change in a typical employee practice, it's certainly better. I mean, I have more tools at my disposal in an employee group than an independent group for sure. But I don't think that's if I could magically immediately change the incentive structure of our voluntary docs, I think I would have, that was a new phrase coming to New York. Everyone calls them voluntary docs here, which I thought was really odd, rather than independent docs. It has to feel awful if you're the employee doc, but there are voluntary docs. If you could magically change their incentive structure, I think we would have very similar effects in terms of the ability to affect behavior change. Because I think very little that has to do with making a doctor do something, which is, you would imagine in an employee group, we would somehow have the possibility of saying, you must do this now. That doesn't ever work. That's when physicians quit and leave. So there's not something magical about employment that makes that dramatically easier. So,
That would have been my hypothesis too, as a payer who's worked with providers in these relationships. Somebody said it earlier, I think in the early presentation, but it's really about kind of being philosophically aligned and dedicated to being in value-based care, right? Seeing it for its value, and aligning those incentives, as you said, Rob. I think what's really important is that you align incentives all the way down to the person doing the work, right? Which is why, not to make this a commercial for Stellar, but why I'm personally excited about Stellar, right? Because I think it's one of the few that actually does that. I would say that first of all, not everybody's going to be employed, right? It's just not going to happen, which is probably a good thing. We love those independent docs. We won't call them voluntary. So it does have an implication for our friends that are employed. But in general, folks are rational economic actors, right? I mean, we got into healthcare because we have some level of altruism, but in the end, we're all rational economic actors, and we need to help folks there. We need to align those incentives properly, and again, down to pretty low levels in the organization to the folks who are doing the work. And you can do that with independent practices, and you can do it with affiliated practices, and you can do it with employed docs. And I used to, and I think about this now. I have a book of Medicare members, and those that happen to be touched by an IORA or a ChenMed. I mean, that's great, but it's a very small part of my book, right? What am I doing for the rest of my members? And that means engaging with not just employed physicians or whatever else. It's finding solutions that address all of them. And that's why I personally believe that as a payer, we have to have a variety of solutions for engagement with providers with respect to value-based arrangements, because one size is not going to fit all. I mean, they're already dealing with the fact that they're have a contract with multiple different payers and different value-based arrangements themselves and the contracts associated with them. But how they kind of push those incentives down, et cetera, is going to be very different. So anyhow, bottom line is, I don't think you have to be employed. I also think that if we were just to focus on that, we would miss a huge part of our population, both from a physician and a member perspective or patient perspective.
The advantage they have, I don't think, is about employment. It's that they were able to start with an intentional model of how they were going to build their culture, their operations, how they were going to incentivize their docs, how they were going to contract. We just don't have that benefit. We're 170 years old as a system, only 8 years as a really a system of multiple hospitals with 400 locations, and they all were fee for service. So that's a different problem to solve. And so it's not employment, non-employment is, I don't think, is the issue. Is the intention from which they started their companies as opposed to ours.
That's a great point.
And Robb Vorhoff, having been an early investor in Oak Street Health and on their board, to Dr. Fields and Dr. Gaffigan's point, What do you think it was about that model, touched upon some of those, but that you saw that really leads to their ability to deliver?
Yeah, I think, first of all, I love the quote from Dr. Gaffigan, if folks are rational economic actors, I'm going to borrow that. Dr. Fields made the right point in that the real power, and I think what helps explain a lot of the success that those models have enjoyed is the focus of the model. And I'm partial to Oak Street, but Chen Ben and IRO and others are all great too. But look, we thought you'd see the earliest and the fastest adoption and shift from fee-for-service to more value-based models within Medicare Advantage because that economic construct had existed for a long time. And so you'd had, at least in certain parts of the country, very successful experiments pushing risk, real full capitation to providers, and shown that the ability for those models to deliver better outcomes to all constituents, dramatically improved patient experience, improved provider satisfaction and retention, lower cost, and better clinical outcomes. But as Dr. Fields pointed out, those models are not built to succeed within fee-for-service. If Oak Street's revenue was only fee-for-service, the care teams are too heavy and too expensive, their panels are too small, it would never, ever make money. And what they did is, with that focus comes a purpose-built model for a successful value-based model. And the benefit that they enjoy with that focus, in addition to the consistency of the training and the culture and the processes and systems, but it's starting with a clean sheet of paper and designing the care model rather than trying to come up with an effective way to change behavior and transition from a successful fee-for-service practice to a successful value-based practice. So our bias in the early innings of that shift towards value was to invest in the models that had that advantage of starting from a clean sheet of paper. I think to Dr. Gaffigan's point, we think this is just now, the momentum in that transition is accelerating, and there's no way that the whole market will look like those models. It's not, you have to transition the rest of the market, and that's a big reason around our enthusiasm for the stellar value proposition. I think the magic here, though, is trying to figure out with existing providers that are going to be independent or affiliated or employed with larger health systems, and at all different levels of sophistication and comfort with value-based models, with those different starting points, how do you consistently help them evolve down that value-based continuum? Because you can't jump into the deep end and hope it works. That's bad for the payer, that's bad for the patient, it's bad for the provider. And being able to effectively manage that behavior change in a way that's a win for everybody involved is the hard part that we should all be pulling for.
Dr. Peters, any thoughts on how you influence people in your clinic? I know you have care managers, you actually have dietitians on staff, so you have a care team that you voluntarily employed even without value-based care contracts fully in place. I'm curious how you thought about that and how that impacts care when you employ all that.
So really the focus has been always on providing great care, and I really think that's true for most providers, and there are some things that make that more complicated, but I found this discussion really interesting. I think that value-based care is something new. It's still very much, there's a long way to go before it becomes normal and mainstream, and I believe it will. And I think that for, at the provider level, learning about the barrier is learning a new way to give care within a new model, which is, it's a very big thing. It's it sounds really nice to be like, well, we're going to pay you for the work that you do, and just great outcomes and just focus on care, but it's a lot of things that, the things I've been learning since I started my training are now kind of turned on their head and have to, even for me, managing a practice and trying to, wanting to be the decision maker, it is anxiety provoking in a way, right? So I think that physicians in general, medical providers, find a lot of comfort in systems that know what they're doing, and being able to plug into those systems, rather than, while also being incentivized to do the right things. rather than just being given ownership of that, just provide value-based care. So that would be my kind of sway on employment versus providers remaining independent in every way.
And perhaps a final question related, both Shirin, you and Robert touched on this point. In some ways it's, can you teach an old way of doing things a new way of doing things? Why or why not?
Are you just avoiding the cliche?
If there was one insight or thought that you would give to anyone, whether it's a provider out there, a staff member delivering, us at Stellar, or anyone out there that's trying hard to convert our system, all the people, participants in the system, to that, what would you tell them? What's the one thing to try and move people?
So I think, so I think that maybe the thing I'll touch on is when I talk to medical students or residents, so super early career people, about why this makes sense, is that I fundamentally feel like it's a more just way of providing care. So try to tap into that intrinsic motivation that I think most people have for justice in terms of how they provide, and at least a sense of equity, even if obviously we're not achieving it. So I fundamentally believe that's true. The problem is, and they hit the real world, quote unquote, right? And then all that kind of can be diminished quite a bit. But I think that's the thing that to hang your head on. I mean, yeah, sure, you can make money at it, right? It can be sustainable, but I mean, I think it just makes more sense for people, and so I think that's the thing I would emphasize. The one thing about, before we leave on transformation, I think is hard, is that whether you're an independent doc, not to say volunteer, independent doc, or a health system, your margins are pretty thin for the most part. And so what a lot of these startups, they had investment to fund the losses in that transformation, right? They had the ability to say, hey, it's going to take us 3 years to get into real risk and get enough numbers to drive performance. That's a hard conversation to have with our CFO. We're going to lose a few $1 million in primary care on top of the millions you already lose, right? Until we make this transformation. That's a hard conversation. So this incrementalism kind of gets, that's where we end up in the sort of incrementalism phase. If there were a way to, I think we could fuel a lot more transformation with some rational way of funding. There's a cost to that transformation, right? It just doesn't happen. And I think that's the tricky problem. So, but justice is, to answer your question.
I think the investment transition, Dr. Phillips alluded to, is really important, but I also want to build on your early career advising point, which I think is really important. We have a shortage of primary care physicians. Those are the quarterbacks of care, and in the most effective value-based models, I think that it has showcased the potential of really good clinical care being delivered by that primary care provider. And I was thinking about when my sister-in-law, so my wife's younger sister, was in medical school and she was trying to figure out her specialty. And we were just getting really excited about this shift to value-based care. And I was like, I really think you should be a geriatrician. And she's like, they don't make any money, I'm not doing that. And I said, no, the world's going to go to value, you're going to be the quarterback of care, this is going to be incredible, it'll be so fulfilling, so rewarding, and very lucrative. And she's now a thoracic surgeon. But I'm excited about it addressing maybe some of that supply challenge and getting people, whether it's justice or delivering great care, not having at least the economic opportunity to turn it, but maybe the best of all worlds.
Right, I agree with that completely. Justice seems like a pretty easy thing to get behind. I also feel, if I was trying to get someone excited about transitioning to value-based care, I would probably just try to tap into what made them want to choose healthcare and go into medicine to begin with, and it really is a way to do what you intended to do when you first started this journey. So I think that's very motivating for me and for lots of other people, and I think that I think medical education is definitely a really important place to focus, because it's there's very little understanding of what's valuable, what's like which clinical interventions really give the most impact. And I think that will shape everything, changing our system a little bit, tweaking our system by adding more understanding of actions and outcomes.
We've made big progress. You went from anxiety provoking to very motivating, so I'm very excited.
Catherine, any final things to add? Completely fine. Well, thank you all for participating in this panel. I found it really interesting that you all unanimously jumped on employment is not really the key. It was actually maybe a mission and a blank sheet of paper, and then that mission, and attracting a bunch of people who want to do exactly that, perhaps for justice, perhaps for better care, in some ways, maybe a rational economic actor who will get the best of both worlds. But thank you very much for participating today, and incredibly interesting discussion. Thank you.